I don't know about you, but when I was in med school and residency, I hated pimping. It was the bane of my existence. I tell you, oh man, had nightmares. I don't know if you actually know what pimping is. If you're not in medical school or in residency, this is probably a foreign topic to you. But the exact definition is pimping is a process through which the most senior medical person, usually the attending, asks the team questions about relevant medical information, typically during morning rounds. Yeah, so that sounds good and dandy, but in reality what happens is during morning rounds, the attendings ask you a very specific question and oftentimes just embarrassing to you in front of the entire group. Like you just feel like you want to become the size of a pea. You know what I mean? It's bad, especially if you don't know the answer and everyone's just glaring at you. Just their eyes are just beating at you. You can just feel the bead of sweat rolling down your face. Oh my gosh. Well, I gotta say, when I was in internal medicine, woo, they love pimping. That's their bread and butter. My God. I remember there was this one attending, let's just say we'll call him Dr. Cullen. That'll be important moving forward. But man, oh man, if Dr. Cullen and I were in the back alley, it would be on like Donkey Kong. That's all I gotta say. But to avoid you running into these same issues, we're going to talk about each topic one by one, starting with pancreatitis. So, what is pancreatitis? You might be asking yourself. Well, the exact definition is aberrant activation of enzymes in the pancreatic ducts, resulting in an autodigestion of portions of the pancreas. So pretty much the pancreas is eating itself, if we're going to keep it a buck. Like, the enzymes in the pancreas are digesting the pancreas. It's almost like when you get really hungry, you know what I mean? When you get really hungry and you're like, oh, my stomach's eating my stomach, that's pretty much the pancreas, what they're doing in pancreatitis. It's crazy. Now, the most common cause of pancreatitis in the US is alcohol. That's a pimp question. But the most common cause in the world is gallstones. Keep that in mind. There's actually multiple causes of pancreatitis. Those include trauma, certain medications, hypertriglyceridemia, hypercalcemia, certain infections, cystic fibrosis, even a scorpion bites can cause pancreatitis. Even pregnancy. Just imagine that. Having a baby and it gives you pancreatitis. That's a bummer. What are the symptoms of pancreatitis? Well, we do have severe epigastric pain, oftentimes radiating to the back. That's pretty textbook. You have nausea, vomiting, feel a little tachypnea. Sometimes people have some jaundice possibly, and even some diarrhea. And the signs, physical exam signs you're going to see. You're going to see some fever sometimes, tachycardia, abdominal distension and pain, even some guarding. Now, on physical exam, you can also sometimes find periumbilical ecchymosis, called Cullen sign. And I gotta say, me and Dr. Cullen, I'd like to give him some periumbilical ecchymosis. But I'd have been kicked out the program and probably escorted off the property in handcuffs. Another physical exam finding is a flank ecchymosis called Gray-Turner sign. So keep those in mind. Might come up in your next pimp session with the Dr. Cullen. As I was saying, causes of pancreatitis, gallstones, most common cause worldwide. Alcohol use, most common cause in the United States. Hypertriglyceridemia, hypercalcemia, medications such as thiazides, salicylates, propofol, sulfa, estrogens, trauma, even certain infections like mumps, Coxsackie, adenovirus, hepatitis, salmonella. and pregnancy. These all can cause pancreatitis. Now, how do we actually diagnose pancreatitis, though? You know what I'm saying? Like, despite popular belief, you actually don't need imaging studies oftentimes. It's not necessary. If you have a high lipase, because lipase has higher sensitivity than amylase for this diagnosis, but if you have a high lipase, clinical picture fits pancreatitis, textbook, don't need to order any imaging studies. Save that belly some radiation. You know what I'm saying? But in some situations, X-ray or a CT can be helpful. And if pain is atypical or the diagnosis is unclear, yeah, you should probably get a CT. CT scan of abdomen pelvis with contrast. Boom. You're probably scratching your head because I said X-ray before. Yes, sometimes you can use X-ray to help. Really cool thing, there's called sentinel loops. So a sentinel loop on X-ray indicates localized ileus from nearby inflammation. So we can use this across multiple abdominal processes. For example, acute pancreatitis, sentinel loop is on the left. Acute cholecystitis, sentinel loop is on the right. And appendicitis, it's in the right iliac fossa. Things you didn't know. Talk about giving yourself your own setup. The attending tries to pimp you and says, what diagnostic studies would you order in the setting of pancreatitis? And you say, CT or X-ray. And he's like, you're partially correct. CT is the correct answer if you have to order imaging studies. And you're like, well, Dr. Cullen, actually, you can use sentinel loops as a ancillary imaging study in the setting of a clear clinical picture and an elevated lipase, and you notice a sentinel loop is on the left side, which is indication of a localized ileus from nearby inflammation. We can use deductive reasoning and my medical astuteness to diagnose pancreatitis. Talk about a mic drop in the middle of rounds. Another thing that might come up, attending might bring up Ranson's criteria, which is a scoring system that helps both professionals predict the severity and mortality of acute pancreatitis. So on admission, there's 5. You have a glucose greater than 200, have an age greater than 55, an LDH greater than 350, an AST greater than 250, a white blood cell count greater than 16,000. Notice how that spells out GA law, because this is Georgia law up in here, y'all. Just remember, Georgia law on admission. They broke Georgia law, so they got to be locked up in the hospital to make sure that they're okay. Now, this is less relevant in the emergency room setting, but just for being thorough. At 48 hours, there's also another Ranson's criteria, which pretty much is the hematocrit decreases greater than 10%, calcium less than 8, PO2 less than 60, BUN greater than 5, base deficit greater than 4, and signs of sequestration of fluids. Now, a score greater than 2 is increased risk of severe pancreatitis. Anything less than 2 is likely decreased risk of severe pancreatitis. What's the treatment of pancreatitis? How are we going to treat this? So actually, we're going to make them NPO, give some IV hydration, maybe a LR bolus, you know what I mean? And we're going to treat their pain and give them antiemetics, And in cases of severe necrotizing pancreatitis, oftentimes you might have to give some broad spectrum antibiotics, such as a carbapenem. If you suspect that this pancreatitis is secondary to gallstones, probably going to have to consult GI for an ERCP. And the dispo, some patients can go home if it's not severe pancreatitis and their pain is controlled and they can tolerate PO. However, if the pain is too severe, you can admit patients to general floor for pain control, vomiting, And they can be admitted to the ICU if there's serious disease, like a Ramson's criteria greater than 2, or acute organ failure, or significant comorbidities. And you might have to call surgery if the patient is hemorrhagic or has complications that are present. I think we pretty much covered up every single thing that could come up in a pimp session with pancreatitis. I tell you, there was one time when I was being pimped so hard, I just wanted to falcon punch my attending in the gut. Give him my own personal Cullen sign, you know what I'm saying? But we made it through. We got it. As always, keep your head up. You're doing great. You're better than what you were yesterday. And that's a lot. Learn something new today. Going to be a great doc. Sometimes you just got to hear that.